as the panel gets situated and people settle in, I'd just like to point out this is much like an event that I put together when I was in high school. Everybody tries to sit as far back as they can. The main goal of the discussion is to really talk about how we can drive healthcare costs down in New York, and I think we're going to hear a lot of good stuff. I would especially like to thank the support of Express Scripts for this discussion, facilitating it and all that kind of good stuff. So without further ado, I will turn it over to our editor, Morgan Peckma, to start the discussion. Thanks.
Good morning, everyone. Thank you for coming. I'm Morgan Peckma. I'm the editor-in-chief of City and State. As Andrew said, we produce a newspaper twice a month, a morning email every morning. I urge you to sign up for it. It's free. It's a very useful tool if you are interested in politics in any capacity in New York State. It's a kind of a synopsis of everything you need to know every morning. And then we put on events like this. Mitra, if you wouldn't mind starting by telling us a little bit about your background and why you think that healthcare costs are so high.
Wow. Okay. And how many hours do I have to talk about healthcare costs? So I'm the executive director of the 1199 SEIU Benefit and Pension Funds. Of course, I'm just going to focus on the health benefit side. Today, we cover 400,000 lives, members and family members of healthcare workers who belong to 1199 SEIU. They receive their coverage through 5 different health funds. 3 of them, our largest 3, are self-insured and self-administered. So we are directly in the line of rising healthcare costs. And we have a number of programs in place that we keep tinkering with and tweaking to try to keep a handle on the healthcare cost curve. I mean, we unfortunately haven't discovered the magic bullet yet, but we have managed to keep our trends below national averages and New York City averages for a number of years, and so have at this point now been able to produce a benefit cost for your sort of typical average family of 4, according to the Milliman Medical Index, that is about 2/3 what the New York City average cost to provide all the healthcare coverage for a family of 4 would be.
I'm head of U.S. Clinical Development and Medical Affairs for Biopharmaceuticals at Sandoz. Sandoz, as you may know, is part of the Novartis Group, of companies. The Novartis Group of companies provides a wealth of products, if you may, including innovative products or pharmaceutical business. We also have consumer health, vaccines, diagnostics, and Sandoz is historically the generics arm of the Novartis Group. Sandoz is also a global leader in the development of biosimilars, which we're going to talk a little bit more about subsequently. We've had biosimilars out in the market since 2006, primarily in Europe, but also in other countries. And we've garnered a lot of experience. We believe that for the pharmaceutical industry is responsible for innovation, innovative products, cutting-edge products, but also there is a need for patient access, and I think balancing a portfolio with innovative products as well as products such as generics and biosimilars that increase access and affordability is key.
Why are healthcare costs? I think your question was, I don't know if you mean specifically in New York versus in the United States. I'd say it's certainly relative. In New York, compared to Louisiana, they're not high. Compared to France, they're quite high. I think there are a lot of reasons, and it would take hours to go through the reasons. Some of them are cultural. They have to do with eating too much and walking too little. Some of them certainly are related around a very ineffective, inefficient healthcare system in this country. Part of that is that the incentives in place are not necessarily the right incentives at the right people. The individuals paying for it are typically not the people making the decision of what they're going to use.
The health budget, right now the state's health budget for health spending, our money, your money, and the federal government money is about $54 billion. There are many involvements that the state has in regard to pharmaceuticals, not necessarily in any coherent system or structure. It comes about because the nature of how the state will be a buyer, how the state will be a regulator, the entities that are directly involved with the state. So sometimes I feel a little bit more like a referee, as we have the independent pharmacists complaining about the chain pharmacies, both complaining about the PBMs. We have the individual groups that champion the cause of a disease or symptom, saying that they need preference and there needs to be a certain prescribing pattern. Why are costs high? I have 2 bookcases full of the publication Health Affairs, which about every other month tells us why costs are so high. But there's one real simple piece of demographic that we have at hand for all of us, and that is simply the baby boomers have hit 50. And that is an enormous pressure on the system.
Dr. Sattler, you spoke earlier about biosimilars, and for those of us who are lay people, could you explain what biosimilars are and how they differ from generics?
Sure. So I think a very general definition of biosimilar is a biologic, and I'll explain what a biologic is subsequently. A biologic that is high quality, safe, and effective. It's a new version of an old biologic that has lost patent exclusivity. That sounds very similar to a small molecule generic, but it's not the same in that biologics are larger, more complex molecules than the usual pill-type drugs that we think about, what I'm calling small molecule drugs. And the other big difference is that small molecule drugs are produced through chemical synthesis, chemical reactions, whereas biologics generally are produced in living organisms, in cells. These can be bacterial cells, these can be mammalian cells. To summarize this, a biologic is more complex than a small molecule. A biosimilar is a version of a biologic that has the same quality, efficacy, and safety, and it's a biosimilar in that it's not exact because of the variability that biologics undergo, but it has to be proven to be as safe and as effective as the original biologic.
And it seemed that biosimilars figured heavily into the Affordable Care Act, but in a way that was kind of undefined. And I was wondering if any of our panelists could kind of explain that.
Today, or previous to this act, so if you go back a couple of years, when a biological product lost its patent, there was no FDA process for which someone could make a generic. So when a normal non-biological product loses its patent, the manufacturers file, instead of an NDA, which is a new drug application, they file an abbreviated NDA. All they have to prove is that their drug is chemically the same compound and is absorbed by the human body in a very similar fashion. What the Affordable Care Act did was basically tell the FDA to create a pathway whereby a biosimilar could be approved through a shortened pathway as opposed to refiling, doing all of the clinical trials, et cetera. The FDA put out a guidance pathway. It's not real workable at this time, so 2 years into this, we do not have a workable pathway.
The draft documents came about in February of 2012, so a little over a year ago. And they are in draft form, and they're a general blueprint, if you may, with not many specifics. But at least now there is a pathway, there is general guidance on what the expectations would be. There is an anticipation that these draft guidances are going to be refined somewhat in the near future.
This past year, 1.4% of our members required biologics or specialty drugs, we referred to them. That 1.4% of our members' utilization comprised over 20% of our costs. To put that into context, our overall drug spend decreased by nearly 3.5%, 2011 over 2012. That's we don't have a name for that in our society, right? You call it a cost curve because it's always curving upward, right? But when it dips, when it goes down, we don't really have a name for that yet. That's more of what we need to see. And that decline in spending of 3.5% obviously something had to offset that 20% upward trend of the biologics, and that was a decrease of 8.8% in our non-specialty drugs. And why? Because there's competition in the non-specialty drug area. There are generics, there are multiple sources.
The other phenomenon that's led to a decrease in the price is the number of drugs that have gone from proprietary to generic. And there's been some stark drops in costs. Our homegrown Pfizer just had Lipitor go off, and their numbers and sales have gone down.
It seems that some states have already taken action on biosimilars, despite the fact that the FDA hasn't really weighed in on it. Would you be reluctant to get involved from a legislative standpoint before it's kind of resolved on the national level?
Well, it doesn't have to be resolved, but most of the legislation in the other states says we'll put it into place when the FDA approves it.
We, as a payer who has basically a fixed pot of money to spend, we are trying to ensure the greatest access for all of our members all of the time. I mean, it's like Medicaid. Again, Senator Hannan referred to the global cap under the Medicaid redesign program that has produced all of these savings. But you're talking about a limited pot of money, and if you're shifting more of it to biologics, as I said, we had a 10% price increase in 1 year, then less of it is available for other things.
To give you a little perspective, the average oral solid, a traditional medication, is about $150 a month. The average generic's about 50, actually maybe even a little less than that, probably closer to 30. The average brand's about 300. The average biological product is $2,000 a month. It's not uncommon for it to be over $10,000 a month per patient. To date, most of the diseases treated by these have been relatively rare. So MS, hemophilia, for example. What should give people concern as they look out to the future is the potential growth rate. There are biologic products in the pipeline for manufacturers to treat much more common diseases, pain, cholesterol, even at half that price. This is going to really put a stress on everybody's budget. Express Scripts estimates that if we have biosimilars come to market in the next 10 years, where patent loss occurs for bioproducts, and have only a 30% decrease, which is a very reasonable decrease in those costs, the United States would save $250 billion in drug spend just from biosimilars.
How do we know that biosimilars are safe for the market?
In Europe right now, there are over a dozen different biosimilars for 3 classes of drugs that currently exist. They have been given to tens, if not hundreds of thousands of patients. And to date, in the 7 years, there have been no unexpected adverse experiences.
Are there any legitimate concerns about biosimilars, or is this just like craven greed on the behalf of biotech companies?
There are always legitimate concerns with any drug, and that's why we have the FDA. And we have a very rigorous process. The FDA, I would say, is the most rigorous entity in the world when it comes to drug safety. The Europeans being close, but I would say slightly behind the FDA. One thing I want to put out, and I'll ask Dr. Sander to comment in more detail, but when we talk about biologic drugs, as he mentioned, they are grown in living organisms. So effectively, the technology is to take, for example, an E. coli bacteria, and to splice in DNA that causes that bacteria to produce something it wouldn't normally produce. So in a simplistic way, that's how insulin, for human insulin, is made. You program the bacteria to produce insulin. You put it in a vat with the food substrate, sugars, proteins that bacteria needs. You let it eat the food, produce the insulin, and then you purify and extract the insulin. So this is partly drug manufacturing and partly agriculture. It is growing in a living organism. And yes, there are differences.
These manufacturing changes are tightly regulated by regulatory agencies such as the FDA or the EMA. And what the manufacturer has to demonstrate to regulators when these changes occur is that the pre-change product and the post-change product will have no clinically relevant differences. That is, there will be no difference in efficacy and safety to the patient.
The clinicians, having made the specific case on biosimilars, I just want to widen the lens a little bit. I certainly don't want to be quoted as saying that there are any companies out there lobbying out of a spirit of craven greed. But when it comes to healthcare spending, there's a lot of money out there. I mean, I think the term, you know, whatever, it used to be the military-industrial complex, that was, you know, something that people would say, oh, those military contractors lobbying for, you know, funds to flow, blah, 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 whatever. Now people talk about the healthcare industrial complex. I mean, you know, there is a lot of money being spent, and a lot of it goes to private industry. And because it's healthcare, it's very easy for them to make arguments about patient safety and about, you know, patient needs and caring for the patient above all. And I would just refer to the example of the durable medical equipment industry, which a few years ago was able to stave off a competitive bidding program in Medicare, somehow arguing that people needed to have Medicare pay, you know, $1,500 for a wheelchair rather than, you know, the $350 you could get it for at your local, you know, device store, because somehow their access or the quality would be impeded by a competitive bidding process that would reduce the number of purveyors in the field. And that cost Medicare $16 billion in 1 year.
I want to thank our panelists. If we can have a round of applause.
My name's Andrew Holt. I'm the Marketing and Events Director at City and State. I'd like to welcome you to this second discussion on the hospital industry in general in New York City, Manhattan particularly, especially with the panelists up here. We will do, I think, a brief Q&A at the end, but I'm going to leave it to Nick to get everything started. Thanks for coming.
To my left, my immediate left here, is the Honorable Assemblyman Richard Gottfried, the chairman of the Assembly Health Committee. In the center, we have Tony Shoris, who is the, excuse me if I'm going to botch this, vice president of NYU Langone Medical?
Yeah, sure.
Okay, gotcha. And all the way on the left, we have Stan Brezanoff, who's the CEO of Continuum Health Partners, one of the leading private healthcare companies in the city. As Mr. Holt prefaced, the topic of this panel is the healthcare delivery system in New York and what potential changes might be in the foreseeable future. Healthcare delivery seems to be constantly evolving in New York State with the advent of new technology, the closure and financial difficulties of state hospitals, and of course the emergence of private healthcare. There promises to be even more changes with the implementation of the Affordable Care Act and the development of the State Healthcare Exchange. So I just want to start off with asking the panel kind of a general, broad question. In your opinion, what has been the most impactful change in healthcare delivery over the last, say, 10, 15 years? And we could start with Mr. Brezanoff.
That's a question that you could come at from a variety of ways, but I suppose from almost any perspective, the most significant thing to occur in healthcare has been my hearing. That's okay. The Accountable Care Act, and because healthcare, as far back as I can remember, has been about two principal issues. Access to care, who gets it, and how is it paid for, who pays. And the Accountable Care Act tried to address both of those issues in the most substantial way since Medicare.
And it's probably not one thing, but I think it's an important question because I think the most important changes that are going on in healthcare, we focus a lot on changes in public policy, and those of us who are in public policy, making public policy like the chairman or others of us who've been around it a little bit think that's the key to the changes in the healthcare system, and certainly they're incredibly important given the role of the government. But I would probably argue the most important changes in healthcare over the last 10 or 15 years have been essentially what in another industry you would call technological. The shift from to ambulatory care, from inpatient care, has had profound impacts on the delivery system and the nature of healthcare in the city and the country. The panel that we just heard before that was talking about the issue of drugs and the use of pharmaceuticals, which have changed the nature of delivery when it comes to lots of diseases, and will continue to profoundly change the way we care for everybody from people with HIV/AIDS to people with cancer. So I think the most profound set of changes in healthcare, I could argue demographic changes are very important. You could argue growing inequality is profoundly important in healthcare. But those kinds of secular, non-interventional, these are just the nature of the business, are profoundly changing healthcare. And the biggest challenges I think we have in New York, in many respects, although Stan's absolutely right, access, quality, and cost are certainly a way you'd evaluate any healthcare system. But you can't deal with any of those without adjusting to the enormously rapid changes in the nature of the underlying technology of healthcare.
Another major change is a continuing shift in the portion of the healthcare dollar that is borne by the patient rather than through the spreading of risk, either to all patients in a plan or to the public. As more and more health coverage becomes high deductible and high copay. So I think there is an enormous amount of change that we need to make in order to have a decently functioning system.
Mr. Shores, you touched on how technology has changed healthcare delivery. Does that apply to the state hospitals as well?
You know, from the time the first person was probably diagnosed with HIV/AIDS to the time it was a massive epidemic in New York and filling hospital beds in New York was probably 7 or 8 years. That's about how long it takes to build a hospital building. And from the time it was filling up hospital beds all over New York to the time it became, for many people, something that could be managed through as a more chronic disease on an outpatient basis, it's probably another 7 or 8 years. Again, the period in which you could probably build a whole hospital. If you'd planned a hospital at the beginning or in the middle of one of those cycles, you would have missed entirely a change in one of the major drivers of inpatient activity.
If you look at the hospitals that are in difficulty or retrospectively the institutions that have closed, you will discover several things, but among them a very heavy dependence on Medicaid as a source of reimbursement. And if you look at the trend line of Medicaid reimbursement, even in New York State, which is one of the most generous and supportive of state governments in the country, that trend line is decidedly down.
Will the Medicaid waiver help kind of alleviate some of these difficulties as well?
I think the hospitals that have been in financial trouble would have been completely wiped off the map years ago were it not for Medicaid, as what was for them one of their only reliable sources of payment. Although what Medicaid pays is nowhere near what it would have been 15 or 20 years ago, trended forward. And so if you look at hospitals, just to pick a place, Brooklyn, that are in serious financial difficulty, there are a variety of factors, including, I think in the cases of some of them, serious management concerns. But also part of it is that neither Medicaid nor insurance companies are paying them what they might have been paying them if the law in New York had not changed so dramatically. It's a short way of saying we don't have as many knee-jerk tax and spend liberals like me as we used to.
Mr. Brezhnev, your company, Continuum, as I said before, is one of the leading private healthcare leaders in the city. What do you attribute the success of your business model to in talking about private healthcare?
Prayer. It is inherently, at least in the Northeast, a very, very fragile business arena. Putting aside the quality and mission-related issues, those of us, many of us, who might be considered successful in operating our businesses, quotation mark, have margins that would get you fired as a CEO in 30 days.
I want to throw it back to you, Assemblyman, and I just want to ask, because I know the governor proposed a pilot program in January that would have allowed business corporations to operate two state hospitals, including one in Brooklyn. It was reported that you played a role in leaving the pilot program on the cutting room floor in state budget negotiations. Can you kind of explain your reasoning for opposing that program, and perhaps speak to what's being done on a state level to combat that?
While nobody's ever going to organize a rally in Albany saying, darn it, we need more assistant commissioners in the health department, the truth is, almost anything that anybody cares about in healthcare in New York, I think, is seriously impaired by the staffing shortage in the health department.
I think, though, the issue that Stan raised is the key one here. I have a suspicion, no evidence for this, that if you woke up in the middle of the night, most of the people who think about the issues of healthcare delivery in Brooklyn, as an example, and ask them, where do you think we need to get to, that actually for most of those people, I don't think the answers would be all that different. I think there's not as much disagreement about where we have to get to. There's an enormous and right now impenetrable barrier in our getting there. In other words, I think most people would probably agree we need a lot more and better primary care in communities that are underserved, that we need better emergency room service in underserved communities, that we probably need to deliver ambulatory surgeries and outpatient services closer to where people live, and maybe labor and delivery services. I think most people would probably agree that extremely capital intensive, very high-end quaternary care services don't need or shouldn't wisely be spread all over the place and are best concentrated because volumes usually produce quality. Nobody wants to go to the hospital where you're the first person that they performed a transplant on. That's not a good idea.
Recently, the Secretary of Health and Human Services, Kathleen Sebelius, announced an initiative that gives consumers information on what hospitals charge across the country for common inpatient services. The data shows the charge master prices by all hospitals and compares it to the prices of Medicare, charged by Medicare, which are typically a fraction of the price. I guess I want to first direct it to Mr. Brezhnev. What are the implications of this new data?
It's a good start. In and of itself, it's not going to make that much of an impact. Most people never see insured people, those who are covered by government payers, where the rates of reimbursement are set, or in the insurance area where they're negotiated. This is almost meaningless, potentially alarming, but almost meaningless to the vast preponderance of patients. What it does, though, make abundantly clear is that there is this disordered, if irregular, if not irrational, element of the healthcare industry where it's very hard to make rhyme or reason out of how these costs structures get developed, what goes into them, and what significance that they have.
And I think we have time for one single question from the audience. Miss in the back.
Question involving several levels of this. Under new regulations, hospitals will be charged for discharging patients whose readmission is foreseeable. But hospitals often discharge patients either to subacutes or to home health care, which is inadequate and therefore triggers a readmission. Do you foresee in the future a closer relationship dealing not only with the cost of an illness over, say, 3 months, but with the health repercussions of how this is handled?
I think that relates very directly to the issue of working towards integrated delivery systems with aligned incentives, so that I don't know that I'd want to characterize the hospital's relationship to your primary care doctor or your home health aides as supervising, but certainly they ought to be working together. And I would like them to be part of an organization that thrives by you being kept as healthy as possible and needing a readmission as little as possible.
I think the answer to your question is yes.
Thank you all for coming out, and let's give a hand to our excellent panel.